So welcome to this lecture about the Pentacam AXL. I want to talk about some new applications of the software, especially for cataract surgeons. My name is Joerg Iwanczuk. I am product manager for the Pentacam and I am based in Germany. Well, the Pentacam is actually two devices in one. You have the tomography that we have in the Pentacam and you have the optical biometry, which is new, and that together makes the Pentacam AXL. You have the smart software that you know from the Pentacam since many years. The beauty is, since you are doing combined exams, you have less chair time, you save a lot of time, you need less space because you have more than one instrument mounted on one table. You have no errors of transmission when you do IOL-power calculation. That means there is no need to put something into an online calculator. That can all be done in the software. And if you already have a Pentacam, you do not lose any data. You keep it. They are still readable with the latest device and much more features. So optical biometry, what are we doing? We are measuring the actual length of the eye. So this is here, for example, the peak. And here we have the single measurements, and out of the single measurements our software automatically quantifies each single measurement, and then it grays out, for example here the upper one that obviously has a bad signal to noise ratio, and it takes it out, and it takes the remaining 5 measurements, calculates them with an artificial intelligence algorithm and present one final value for the actual length. Though there's no need to do any manual iteration, that's done by the software. And you see we have the standard infrared image that we had before, but now we have also the image where you see the blood vessels. So you can use that image to superimpose during cataract surgery to compensate for cycler rotations and other stuff. Here's again, this is a final value. These are the single values, and you see the final value differs from the single measurements. And the signal to noise ratio has to be above 6.3. If it is below, quality specification will show you that the measurement is not okay and you have to redo it. What we are offering in the Pentacam to give you a routine that you can use every day is at first a screening routine. Because when you have many patients to do in the clinic, you want to do them in the same order, looking to the same values, to the same displays, to the same numbers. And this screening routine that we are proposing for cataract surgery is you start with a fast screening report to get an overview if there are any abnormalities. The second that we recommend is to look to the Bellin-Ambrosio display, that you see any early ectasia or form-fused keratoconus which may influence the result of your premium IOL implantation and calculation. We offer corneal optical density, so you see Fuchs endothelium dystrophy, you see any flaps or other abnormalities in the cornea, and we have the Scheimpflug images where you see the lens density, and we also have the grading PNS, Pentacam nuclear staging, to control femtolaser settings. The next routine that we are proposing is for IOL selection. Again, 4 steps, and this is shown in the Cataract Pre-Op display over there. 4 steps. At first we look to the high order aberrations and to the chord distance, means chord mu distance between vertex normal and pupil center, to check whether this patient is suitable for a multifocal IOL. So we have cutoff values displayed there. We look to the spherical aberrations, and these are the total spherical aberrations of the whole cornea. It's not only anterior surface derived, it's from the full cornea. Then we show you actual map, means anterior topography, and total corneal refractive power to check whether there's an influence from the posterior corneal surface with regard of the magnitude, the angle and the regularity of the corneal astigmatism. And then we look in detail to the values, what is a keratometry anterior surface derived and what is a keratometry from the total corneal power, because we are using that value for IOL-power calculation for torics. And here are a few examples. This is our corneal optical density display. You see here in the map there is obviously something which is abnormal, and if you look to the details you see in the endothelium we have opacities. That's early endothelium Fuchs dystrophy. And now imagine you do IOL-power calculation, you implant a nice multifocal IOL, and this disease develops, grows over time, progresses. What do you want to do? You can explant the lens, because if you do surgery you get a hyperopic shift and the patient will not be very happy with his vision. So it's better to detect this early enough and then do either a combined treatment or do the cornea first and the cataract after, but at least you have detected it, and then you can make your plan on how to deal with this patient. The next what we are offering is, again, you see that area that is very red over here. And do you see this? This is a flap. This is a post-LASIK flap. When you look to the topography, this is obviously not visible because the ablation was only 3/4 of a diopter and the cornea was very steep and the zone was very big. So when you do IOL-power calculation for that, the risk to overlook it is very high, and then you end up hyperopic. And we know then we have our problem, because hyperopia is not forgiven by the patient. Okay, coming now to the 4 steps how to select the best IOL for that patient. It's in the Cataract Pre-Op display. And we developed this display together with Professor Maeda from Japan. Oops, I was too fast, I'm sorry. So step number 1 is you look here to the high order aberrations. These are the total high order aberrations. If this value is below 0.3, the patient is from corneal optical conditions suitable for a multifocal IOL. That means he has less aberrations, not to reduce the contrast sensitivity that much. If the patient likes it, that's the next step. That's what has to be discussed with the patient. But you have a good guideline if we could recommend a multifocal. Step 1 that also belongs to this is here chord mu. Chord mu, distance between vertex normal and pupil center. If this value is above 0.5, you might want to be a bit careful with a multifocal IOL, because it will never be centered to the visual axis, because the capsular bag is out of center. So cutoff value 0.5 over here. And now we look to the maps. I'm too fast for that, sorry. We look to the maps, we look to the anterior surface topography and to the total corneal power. And we want to see that if the posterior surface has an influence. In this example, you see the axis of the astigmatism is very straight. It's a very regular astigmatism. But if the posterior surface contributes, it might be that the axis shift compared to the anterior surface. Or the astigmatism is not that regular anymore, because the posterior surface has a bit of irregularity. So this is a qualitative inspection. Here there's nothing to worry. It's a pure, regular, nice astigmatism with the rule. Okay, step number 3. We are looking to the spherical aberrations. The spherical aberrations are displayed over here. Whether an aspheric IOL is beneficial for that patient and which aspheric IOL should we use. Should we use an aberration neutral one, or should we use the Alcon one with minus 0.17, or the one from AMO or Johnson & Johnson now with minus 0.27, trying to give the patient the best quality of vision. And then last but not least, the most interesting point is when it comes to the calculation of toric IOLs, we are looking to the keratometry. Here you have the anterior surface, here you have the total corneal power. So here we look in detail, how does a posterior surface contribute? In this example you see the difference does actually not exist it's 1.4 degrees. This is nothing, yeah. And also the average of the difference between the magnitude of the astigmatism, anterior surface to total corneal power, is in this example exactly the same. But there are cases where it is different. And now you have a basis that you can go into the discussion with the patient. We also did some clinical studies to compare how does a Pentacam correlate with existing released instruments. That was a study done around the group from Thomas Conan in the University of Frankfurt. So they compared the Pentacam AXL with the IOL-Master 700 and 500, and they also checked the repeatability. In conclusion, they found no statistical significant differences between the devices. But let's look a little bit to the details. So they did 2 measurements for each patient, for each eye, for each device. Here is a p-value, and the lower the p-value, the better it is. And when you look to the keratometry and you compare IOL-Master 500 to 700, the 700 is not better. It is the same keratometry. But when you look to the Pentacam, here the keratometry is definitely better. And keratometry is a key parameter for IOL-power calculation. In another study that was also published, we see the same results. That was done from the University of Heidelberg together with Kiel and Leipzig. And here they compared the Pentacam AXL with the IOL-Master 700. They found similar results. Overall, there are no differences. And now let's look again to the details. The interglass coefficient for the mean keratometry is excellent for both devices. When you look to the vector values that you use for the calculation of astigmatism, you see the repeatability of the Pentacam is again better than that. So for torics, we definitely have the benefit. For ACD, it's same. And for the actual length measurement, well, it's in the 3rd digit, so there is actually also no difference. So that's a good basis to start with. What I want to highlight, because that's often overlooked, is which values really matter when we do IOL power calculation. And it is definitely curvature. If you have a difference of 0.1 millimeter, this ends up in approximately half a diopter error. So you would use another IOL, another power. Differences in the actual length of about 30 micron result in 0.1 diopter. This is negligible. This is pretty small. But when it comes to the positioning of toric IOLs, a misplacement of 10 degrees reduces approximately 30%. So you see how sensitive this toric IOL calculation, positioning, implantation, stability, surgical-induced astigmatism, so many parameters come together, and that makes it often very hard to predict. Of course, misplacement of 30 degrees, you lose almost the effect. So keratometry matters most, and that's my take-home message for you when you do IOL power calculation. So which formulas do we have in the Pentacam AXL? You have actually a solution for every eye, for every cornea. Doesn't matter how it is shaped. We have the standard formulas, Holiday 1, Hoffer, Q, SRKT, Hygis. You have the Barrett Universal 2. And now you have formulas which are customized for the Pentacam. No history formulas for post-myopic LASIK and post-RK. And you also have the Barrett TrueK. If you have the refraction prior surgery, you get a more accurate calculation. If you have keratometry prior surgery, you can use a double K. We have toric calculators, our own one based on TCRP, the Barrett toric calculator, and via interface we have many other software features, software programs connected. What is new? Now we have the Olsen formula integrated into our IOL calculator. It's a ray tracing calculation. So it doesn't matter which shape the cornea has. You can do an IOL calculation for that. If it is myopic or hyperopic LASIK, if it is radial keratometry, radial keratotomy, if it is a virgin eye, if you have any corneal grafts, if you have DSEX, DMAX, it doesn't matter. If you have high keratoconus, and even for horses, you can use that formula for IOL-power calculation. It doesn't matter what the shape is, and that's the beauty of it. And this is also unique in the biometry society. The beauty is the AXL comes with all the IOLs included. There's no need to do any import or Excel or whatever from the internet. It's in the device itself, and we get the information from the manufacturers because they have interest to have their IOLs included, so we have a direct interaction with them. Yeah, then we still did improvements in the software. We made a new software for a better ray tracing, so that improved our repeatability and also the calculation of total corneal refractive power. And so we redid a study that was published before from Dr. Savini, close to 60 eyes, 33 with the rule and 25 with against the rule astigmatism. Pentacam measurements and ultrasound biometry was used in that sample. And we did the calculation with the new software. And the outcome is very nice. That's our own calculator. Here the upper line and the lower line is the Barrett calculator. So the mean absolute error is relatively same. When you look into the differences between the predicted and the post-op astigmatism, there's also very small differences. Here our calculator is a little better. From the mean absolute error, Barrett is a little better. So considering the posterior surface seems to really have a benefit. That's our calculator. You have everything that you need for the calculation, also for the selection. And here you see we have chord mu, the spherical aberrations as well as the higher order aberrations are also in the calculator. So everything is combined. When you look to the printout, you have the patient's demographic data over here, the examination data. We talk about the left eye. You have the orientation axis of the toric IOL, your calculations, and here your estimated residual refraction. In a nice printout that is easy to read, here for example, we calculate the SEQ with Hygis and the toricity using total corneal refractive power to consider the posterior surface. And now let's look to two clinical cases that I brought with me. A 60-year-old female suffered from subjective loss of visual acuity and increased glare. That was a corrected distance vision acuity on the right eye, 2036. This was her refraction, a little bit myope with an astigmatism. Left eye, 2040, -1, -3/4 of a diopter at 75 degrees. She has senile cataract but no corneal pathologies. They did Scheimpflug imaging and they target post-op refraction for emmetropia, and the fundus was also nice. Now let's go further. And here you see what matters. On the right eye, the anterior astigmatism was 0.9 on the right and 1.7 on the left. The total corneal power was the same for the right eye, but a different one from the left eye. The spherical aberrations suggested to use an aspheric IOL, and the high order aberrations are below 0.3, so you could recommend a multifocal IOL. Okay, let's look to the calculations. They implanted the ZCT 1.5 from AMO in the right eye and the ZCT 2.25 in the left eye. This is our own calculator. This is a predicted post-op astigmatism. This is Barrett, this is Olsen, the ray tracing, and this is the outcome. For the right eye, That's our own calculator, that's Barrett, that's Olsen, this is the outcome. Now let's switch back. The right eye had the same value. The left eye had a different value. You can have a nomogram trying to compensate for the influence of the back, but this does not work all the time. It works for many cases, but it does not work for all the cases. So it's better to measure that. Let's look to case number 2. Is a 70-year-old male, also senile cataract, no corneal pathologies. This is the astigmatism of the right eye, anterior surface, total corneal power. Let's look to the calculation. They implanted a T4, the SN-T4 from Alcon, at 12 degrees. This is a prediction of the Savini calculator. That's Barrett, that's Olsen, and it comes out plano. Let's switch back. Here we have also differences between anterior and total corneal power. And in this example, the prediction works. So it can work, but it also cannot work. But you don't know. And that's the point. So we think it's better to measure the posterior surface and do a calculation based on that what we really measure. Yeah, we have the link now to Leica using TrueVision. So what we are doing is we superimpose the iris image that you have a live tracking during surgery. So you have the image from the Pentacam, you have the live image during surgery, and when you lay down the patient, you have cycler rotations. And we compensate this while matching the Pentacam picture. And then we can compensate for the angle. And we can also have a macula surgery because the angle for the toric IOL, the axis, the line is mirrored into the microscope to the oculars. So the surgeon sees exactly on how to orientate the IOL. And also when the patient is moving during surgery, the system is tracking the motions, the eye motions. Then we improve the workflow and have a higher precision. We also made a new article together with Heidelberg. You can have it over there and take it home with you. It's a combination of how you can combine Pentacam with keratograph for dry eye assessment. So you see the Pentacam is a central unit. It's linked to femtosecond lasers like the LENSAR system. If you do intracorneal ring surgery, the Pentacam is the device of choice. If you do cataract surgery, the Pentacam is the device of choice. If you do IOL-power calculation, the Pentacam is again the instrument. If you do laser refractive surgery, if you do cross-linking, if you do contact lens fitting, or if you want to have an interoperative guidance system, the Pentacam is a central unit. So you do one measurement and you have all the exams and all the information that you need. Thank you very much.